when she developed nausea, vomiting, and decreased appetite. So with this complaint, she went to a local doctor and was treated with some medications. This nausea, vomiting worsened over the next 2 days when she developed fever and loose stools. So it was a high-grade fever, a temperature of around 101 to 102 degree Fahrenheit. It was not associated with any cough, expectoration, rash, joint pain, and was relieved with paracetamol, no diurnal variation. It was associated with loose stools, which occurred simultaneously with the development of fever. Loose stools occurred almost 6 to 8 times per day, and it was associated with blood in the stool and abdominal pain. There was no foul smell in the stool. So along with the loose stool, she also developed abdominal pain. It was a diffuse abdominal pain with moderate to severe in intensity, colic in nature, without any radiation. So for this fever, loose stools, and abdominal pain, she got admitted in a local hospital in Nepal and was treated with some painkillers and IV saline and some antibiotics, the name of which she doesn't remember. After 2 days of treatment with saline, antibiotics, fever, loose stool, and abdominal pain improved. After admission to the hospital, she noticed that she developed a drop in his urine output. Initially, she used to pass around 4 to 5 times of urine per day, and now she passed 2 to 3 times per day. And the amount was also reduced as compared to previously. This was not associated with red or cola colored urine, any froth in the urine, any flank pain. On direct questioning, she remembers that she was investigated this time and was found to have a creatinine of 2.2 on admission, which gradually increased to 5 milligram over the next 2 days. She was also told that she was leaking some protein and blood in her urine. 2 days post development of this decreased urine output, she developed facial puffiness and edema. Initially, she noticed puffiness around the face and eyes, which was more in the morning when she woke up. It gradually progressed to her feet. She remembers that this time she was found to have high blood pressure and required one antihypertensive drug to control her blood pressures. There was no shortness of breath, abdominal distension, chest pain, dizziness, palpitation, or syncope. During the stay in the hospital in Nepal, she was told that she will require hemodialysis and likely a kidney biopsy. But she didn't undergo the hemodialysis or kidney biopsy, and from Nepal she came to Medanta for further management. Here, after admission, she remembers that her creatinine was told to be 7 milligram per deciliter, and she was also told that she was having anemia and will require blood transfusion. After this, she had a significant hospital course, which I would like to discuss later on. There was no history of rash, alopecia, oral ulcer, or joint pain. No history of any seizure or altered sensorium. No history of any alternate medication.
So this is your present history, yes? Till she came to you. Yes. Is that right?
Yeah. Yes.
Okay. Tell me, in a 14-year-old girl or a 14-year-old child, what are common causes of AKI that you would think of? Don't forget the history. What are common causes? Like, for example, if somebody comes with no urine volume and is 78 years old, you would think of either prostatic hypertrophy and, So similarly, in a 14-year-old, what will you think of as a cause of renal disease or renal failure requiring dialysis? Not in this patient. You understand the question?
Yes, sir. Yes.
Okay.
Sir, any post-infectious cause?
एक देखो ऐसे बोलने की आदत डालो, बोलो से post-infectious glomerulonephritis. Agreed. But why you say anything post-infectious?
I would go a step before. I will say that in today's setting, I would like to say whether it's community acquired or hospital acquired. So it is extremely important to try and decipher the etiology based on where is the patient coming from. If she's coming from a community, from a rural background, then we'll have different causes. While if the patient is undergoing cardiac surgery and then developing an AKI, then it will be different. So you can start with that. That will show a clarity that yes, you are well read with this subject.
तो बताओ ये तो कम्युनिटी से आई, कम्युनिटी वालों में क्या क्या, एक पोस्ट इन्फेक्शियस ग्लोमेरुलोनेफ्राइटिस, अग्रीड, और बोलो।
So we can basically divide it into the components. First, the involvement of glomerulus. Then we can include involvement of interstitial.
You just tell us 5 leading causes of renal failure in a 14-year-old that you would think of and you have seen, or you may not have seen, but at least you must have heard of.
Post-infectious glomerulonephritis.
बस हो गया.
IgA vasculitis or IgA nephropathy.
What sort of an IgA nephropathy will a 14-year-old girl have?
Crescentric, if it is crescentric transformation.
No, inoculum purpura.
HSP.
Okay. ऐसे बोलना होता है. देखो तुम एक के आगे नहीं बढ़ पा रहे हो. See, you know, Debayan,
yes,
I have just asked 5. There will be 50. No? And
community में आ रही है तो सबसे पहले तो severe gastroenteritis ही बोल दो ना. That can also be. और
AKI का कॉमनेस का कारण
रिलेटेड है तो बताओ कि डायरिया रिलेटेड कौन जो सर ने बताया HUS है, फिर जाके टॉक्सिन्स है, फिर जाके एंडोटॉक्सिन है, तो ये तो बताना ही है बेटे, इसमें तो रुकना ही नहीं है.
Commonest cause of AKI in a 14-year-old girl will be gastroenteritis, dehydration, AKI. है ना? कम्युनिटी में यही देखने को मिलेगा. ठीक, चलो तो फिर पोस्ट इन्फेक्शियस हो गया. तुमने IgA बोला तो मैंने I have defined that IgA into a little more sophistication in inoculum purpura. ठीक है, और क्या? तो 3 में से 2 बताए तुमने तो अभी.
thrombotic microangiopathy.
HUS हो गया. ठीक है, agreed.
Any drug induced like
which drugs?
Commonly antibiotics or NSAIDs.
बेटे ऐसे तो ना बोलोगे. एंटीबायोटिक एसिड स्पेसिफिकली वी हैव टू इन्यूमरेट अगेन. ऐसा सेड कि 4-5 जो नेफ्रोटॉक्सिक ड्रग्स हैं इस सिचुएशन में उनका नाम बता दो. ठीक है ना, वो ज्यादा जरूरी है. एनसेड्स एंटीबायोटिक्स तो बहुत ही ब्रॉड स्पेक्ट्रम हो जाएगा ना.
एंटीबायोटिक्स लाइक aminoglycosides.
Yes, aminoglycoside, yes.
Any NSAIDs. Other antibiotics like cephalosporins or quinolones can also cause acute intestinal nephritis, which can lead to AKI.
Okay. चलो अब देखो, it's a student who has come with nausea, vomiting, loose stools 6 to 8 times, and there is blood in the stool. Is that right?
Yes.
There is joint pain or no joint pain?
No joint pain.
No joint, but there is fever.
Right? There was fever. Yes.
Okay. So in the history, how would you elucidate that these loose motions were enough to cause AKI?
Yes. Very
not enough to cause AKI? Dehydration and AKI.
बेटे इसमें तुमने सिर्फ फ्रीक्वेंसी बताया.
यही तो वॉल्यूम नहीं बताया.
नहीं किया बेटे.
हाँ,
वॉल्यूम
वॉल्यूम बताना. हाइपोटेंशन हुआ या नहीं हुआ? when she reached the hospital, was her blood pressure okay? How much saline did she require? Did she require 2 bottles or she required 20 bottles? No?
Yes.
These things in the history will make your examiner understand, look, this is not dehydration AKI. So this is diarrhea associated AKI, but not related to volume. है ना? दोनों अलग थिंकिंग की लाइंस हैं.
Yes.
एक में आप डिहाइड्रेशन, उसका मैनेजमेंट की तरह सोचो. एक तरफ आप सोचोगे यार 6 to 8 स्मॉल स्टूल्स हुए, इसमें ब्लड आया एंड the child has stopped passing urine. So what is it? Is it a vasculitis? Is it a HUS? You know, then you will think of non-volume related. Pre-renal की जगह renal में आ जाओगे आप. AKI को ऐसे डिवाइड करते हैं ना, pre-renal, renal, post-renal. So you have to, in your history, tell us that this is not pre-renal, this is not post-renal, this is renal. है ना? So number of stools, volume of stool, what was the blood pressure, how much fluids did she require to resuscitate, or was it just 2 bottles saline लगा दिया just to cover up the diarrhea, right?
Yes.
So this is important to tell in the history, right?
Similarly, as you said, patient received antibiotic and painkillers. बेटे उसको भी ना कोशिश करो देखने की कि क्या मिला उसको. Because in a setting of the underlying diarrhea, as Sarah said, if a patient receives further, nephrotoxic agents, then the situation will get compounded. While on the other hand, if the patient received a safer antibiotic and a safer NSAID, then probably the physician will be saving, right? So we need to decipher the etiology of AKI as of now based on the history. Very, very important to take all the factors, all negative factors into account, which will contribute to her. See, even the presence of a small nocturia before the pre-morbid condition could point to a underlying, existing kidney disease. So it is very important for us to find out whether the patient had symptomatic or asymptomatic pre-existing kidney disease or not. A patient may be having asymptomatic, some sort of a congenital abnormality, which could have, laid the foundation for this AKI. Have you understood what I wanted to convey?
Yes.
So in your history, Debayan, you have not mentioned so far, at least unless you are going to tell us more, that was there any underlying chronic kidney disease? And this diarrhea just precipitated the whole thing, and it is all acute and chronic. So will you tell us in the history, or is this all?
So there is no suggestive of any previous existing kidney disease.
Nee, what? Well, how did you know? You haven't told us anything. In some blood loss in the stool, she has required blood transfusion. Does that mean that she was having anemia? She was already 7 hemoglobin and some stool blood has made it worse and she requires transfusion. Don't get biased by the diagnosis that you know. Your examiner will not discuss HUS. He will discuss everything else. Right? Because the case is from your center. So he knows you know the diagnosis. So your history is totally biased towards HUS. किसी का म्यूट करना पड़ेगा. पुनीत, किसी का म्यूट करना पड़ेगा. सीता पाइकरा.
So, tell us, in a 14-year-old lady, a young girl, what are the suggestions that she has a chronic kidney disease? What are the symptoms?
ये बताओ.
ये बता दे. चलो, ये नहीं है, इसको ना हो. क्या फैक्टर्स हैं 14 साल की बच्ची में जो कि आपको इंडिकेट करेंगे कि शायद इसको अंडरलाइंग क्रॉनिक. वन इज, सर ने बता दिया आपको, एक एनीमिया, प्रेजेंस ऑफ एनीमिया in a pre-morbid condition would highly suggest that probably are we dealing with chronic kidney disease, or are we dealing with some condition which has resulted in severe anemia just now with the present condition, right? Any other thing, but
any delay in a growth?
Very good, growth. Yes, absolutely. You should mention in the history also whether the child has been growing properly as per her quartile or not, as per her percentile or not. That's extremely important. Yes. What else?
Any urinary complaints like recurrent UTI or any double voiding or any symptoms previously?
Very important. Yes. Anything else? Yes. What else? Both the things you have said is absolutely correct. Theoretically बता दो और क्या factors होते हैं theory और examination में which can give you a clue to the underlying chronicity.
देबायन, देखो मैं बताऊं, तुम्हें ये बताना है कि this was a normal childbirth. There were no delayed milestones. There was no enuresis, right? The growth of the child is equal to her siblings. 2, she was as playful as her schoolmates. She has no mental retardation. She doesn't have nocturia, right?
One of the common presentations of CKD in children can be osteodystrophy. चाहे वो rickets करके हो, चाहे वो bilateral fracture neck femur. I have seen 3 subjects at that age group in my career in last almost 3 decades. They just came with osteodystrophy. So these are some band keratopathies, whatever you want to call them. So you need to, and they can be converted into symptoms. Like patient did not have any aches or pains, pain in the joint, suggesting a osteodystrophy. That means that yes, you have a knowledge that this can be one of the presentation of CP. Okay? Am I right, Sandeep? Or anything we can always add?
ये तो important है, ठीक है? Any history of edema, any history of childhood kidney disease, parents will tell you. Must ask, right?
Yes.
So all these you have to enumerate. You know, why are you fixed? No, if you have a patient like this, Debayan, they will not assume that this is AKI. They will assume, you know, commonest presentation of chronic kidney disease is acute on chronic, right? So suppose she was having a reflux nephropathy.
Yes.
This diarrhea infection came and the girl who was having, say, 5 creatinine became 7, right? Or 2 creatinine became 7, 2.8, whatever was the first creatinine, 2.2. So 2.2 is how much GFR in your, what do you think is the GFR with a 2.2 creatinine in a girl? What was her body weight?
Body weight was 42 kg.
So 42 kg, 2.2 creatinine. What do you think will be the GFR roughly? Not more than 30 ml. Okay, right? And now it is what? 7 creatinine. 7 creatinine is what? 10 ml or 7 ml? No? So this can happen with a small infection. And that is what she had. She had fever, loose stools, and blood in the stool. So it must have been infective diarrhea. And, you know, she is down and out now. So HUS has to be kept at this age, second or third decade. VUR, reflux, has to be kept in mind. Nahin? So, you know, it's not all that straight. Unless in your history, if you had told us all these things, we would have said, yes, this boy has ruled out a chronic kidney disease in this child. So we must not look at this child. She, you know, somebody with small amount of blood has developed anemia requiring transfusions. Right? So that has to be kept in mind, right? So you must tell, तो समझ गए हो अब क्या क्या बोलना है?
Yes.
Growth milestones बोलने हैं, ठीक?
Yes.
Enuresis, and कि भाई urine control at the same age as generally most children do. Yeah, was she bedwetting till 10 years, 12 years of age? Or is she still bedwetting? And these are subtle signs that tubular dysfunction is going on. And tubules are not all right. Then, जैसे Dr. Singh ने बताया ना, renal osteodystrophy in growing age, तो bones ही तो सबसे ज़्यादा bear करेंगे brunt. So renal osteodystrophy के signs वो क्या होते हैं? Playful नहीं होता child, थक जाता है child, right? Some may give you history of rickets or fractures, right? Then growth retardation. Acidosis leads to bone mineral disease, and mineral bone disease leads to growth retardation, right? Is that right?
Yes.
Okay. अब rash तुमने बोला, there is no issue. What special rash would you be looking at in this child?
Typical vasculitic rash that
कौन सा होता है? Vasculitis rash क्या होता है?
Palpable blanching.
देखो palpable होगा तो blanching नहीं होगा.
Non.
Palpable purpura is vasculitic,
No. Yes.
right?
Yes, sir.
Which diseases you have palpable purpura?
In this age, this presentation HSP.
Correct. Where do you get rash in HSP?
In the back of the thigh or buttocks.
Correct. Very good. Right. What other rashes have you heard in vasculitis? One is this. Suppose somebody has gangrene in the fingertips. What vasculitis will you think of?
Cryoglobulin.
Very good. Somebody has a malar flush, malar rash. SLE, है ना? तो ये आपको बोलना है. Somebody has a rash around the eyes. What is that? Heliotrope rash सुना है? What is a heliotrope rash?
Raccoon amyloidosis.
No. नहीं तो हर एक रैश बताना है आपने, अलग अलग बताने हैं. So you have to tell what is the rash in rheumatic fever. क्या वो सिलेबस के बाहर है, किडनी नहीं है.
connection.
Hello.
Hello. Yes sir, the connection actually broke.
अब ठीक है.
ठीक.
अच्छा. What is the rash in rheumatic fever?
Classical जो major criteria वो बता दो सर को पहले. See, nephrology, DM or DNB does not mean that you are supposed to forget your internal medicine. No. Half of the questions can be on internal medicine as well.
Correct. चलो.
एरिथीमा क्या होता है?
एरिथीमा क्या होता है बताओ?
एरिथीमा नोडोसम.
नोडोसम. एरिथीमा नोडोसम किस में होता है? क्योंकि तुमने बोल ही दिया तो बताओ. Not rheumatic fever. That one is sure. Okay, you be sure. That's not the right answer. Now tell me, where do you get erythema nodosum?
Sarcoidosis.
Yes, one is that.
Correct. दूसरा differential जो sarcoid का होता है वही होता है. Tuberculosis.
Tuberculosis, sarcoidosis, drugs. ये तीन
याद रखना है. ठीक है. तो रैश को अगर तुमने बोला है रैश तो मैंने कहा पूछना भी पड़ेगा. अच्छा तुम्हें हाइपरटेंशन कैसे, इस बच्चे में क्या नॉर्मल बीपी होता है 14 ईयर ओल्ड में? अब तुमने तो प्रेजेंट किया था तो पढ़ लिया ही होगा कि व्हाट इज द नॉर्मल बीपी एट 14 इयर्स 10 इयर्स. नॉट दैट आई नो ऑफ, यू शुड नो यार. व्हाट इज द BP at 14 years of age, right? तब तो आप hypertension define करोगे, है ना?
And which cuff will you use? Which cuff will you use? How will the cuff impact the blood pressure readings? That is also important, right? You need a smaller cuff, because this girl is likely to be having a lesser diameter of the. It's an indirect measurement. You only compress the arteries indirectly. So obviously, we have to use a smaller cuff, and the normal values for the 14-year-old female would be different. Okay.
अभी डॉक्टर साहब ने बैंड किरेटोपैथी बोली थी. What is band kiretopathy, if you know? नहीं देबया? चलो तो ये पढ़ना. जो साइंस होते हैं क्रॉनिक किडनी डिजीज के, उनमें ये बैंड किरेटोपैथी आती है. नहीं? चलो, दिस इज अ वेरी सिंपल क्वेश्चन. Tell us some things which will tell you in your examination and investigation which will say chronic kidney disease.
Ultrasound.
नहीं बताओ, शुरू से बताओ. चलो अल्ट्रासाउंड बोल दिया तो बताओ. What in ultrasound will show?
If the ultrasound shows any structural abnormality, any small size kidney,
bilaterally small kidneys, bilaterally small scarred kidneys, they are sign of chronic kidney disease and an ultrasound. But you also know that there are causes of chronic kidney disease where the ultrasound will show normal size kidneys. So what are those?
In this 14-year-old child?
No. Normal size kidneys.
Diabetic nephropathy.
Very good. What else?
Amyloidosis.
Amyloidosis. What else?
HIV.
HIV, right. Wherever there is a rapid progression to chronic kidney disease, the kidney doesn't have enough time to become small. And you pick the 3-4 months mein agar chronic kidney disease ho gaya hai. So most of the crescentic genes, if they present as chronic, haven't we biopsied patients who have 7-8 creatinine? There are some RBCs in the urine, the ultrasound normal size kidneys, and when we biopsy, we find chronic kidney disease and chronic crescents, fibrotic crescents. So this is often biopsies that you do where it is chronic and yet you do a biopsy just to be sure that you are not missing anything. Okay? So, okay. Chalo. Now we come back to your patient, right? Now you tell us anything more in the history you want to tell?
But progress बता दें हम तो आगे बता रहे थे ना. You said that you will continue further. So
yes, of course. And this patient.
Have you understood what questions did Dr. Sanjay told you?
Yes,
and the importance.
Yes.
So whenever you have to present a history in AKI, you have to ensure that these questions are either included or excluded. Okay? हाँ भाई आगे बताओ.
After admission into the hospital, she underwent a right IJV HD catheter insertion, followed by plasmapheresis. She was she total for the 10 consecutive days she underwent daily plasmapheresis. She was also told that she had severe anemia and she required 6 units of PRBC transfusion, and her platelets were also low, so she required 2 units of SGBC transfusion and 9 units of RDBC transfusion during this 10 consecutive days of her plasmapheresis. After that, she had a improvement in her urine output, and her creatinine also gradually settled, and she is currently undergoing alternate day plasmapheresis. This is the hospital course.
Okay. हॉस्पिटल कोर्स में आपने सिर्फ यही बताया कि क्या इलाज हुआ, ठीक है ना? You also have to indirectly, at least if not directly, tell us how is she investigated. And you know, you are the treating doctor, right? You are the treating doctor,
yes.
And unless you or unless the patient has told you all this, are you a treating doctor or the patient?
Yes, sir. She is admitted under us.
She is admitted, right? So patient at least say that patient underwent a plethora of investigation and a specific diagnosis was made. Based on that diagnosis, patient straight away underwent plasmapheresis. Why not only hemodialysis or again straight away plasmapheresis, right?
Yes.
Because we thought of a specific situation where we think that this modality of management was the preferred method. Otherwise, in a patient who's got an AKI, I would expect as an observer and a teacher or a layman, that patient should undergo hemodialysis, right? So, what do you say, Sanjeev?
हाँ नहीं ठीक है. अब ये बताओ, if your history is over, you tell us what is the physical findings पे जाओ.
वो बता ही नहीं तुमको.
So she was on general examination. She was alert conscious.
मैं बताऊं before you go further. In the history and everything, you haven't told us anything, past history, personal history, family history.
Minarki हो गई नहीं हुई उसको.
कुछ भी नहीं बताया तुमने.
Yes, actually, I had taken all the family history, the developmental history.
Yes, बोलो अभी history में ये बताना है मैंने, तो बताओ. अच्छा बताओ पहले past history.
Past history, she has no significant past admissions or any significant history in the past history. And in the family history, she has one elder brother, a mother, father in the family. None of them have had a similar illness. Her father is diabetic since 5 years. Her mother has no comorbidities.
Okay.
And none of them have any kidney disorder, known kidney disorder in the family.
Okay. Personal history?
So, in the bladder, I have already discussed. She had a decreased urine output after initial symptoms.
Personal history बताओ ना.
So, bladder, bowel, sleep appetite. Bowel is known.
Personal history in a young girl, you will have to tell us whether she has attained menarche or not, whether she is addicted or not. ऐसी substance abuse की कोई history तो नहीं है. नेपाल में बड़ा substance abuse होता है ना?
Addiction नहीं.
तो ये बताना पड़ेगा. तो menarche हुई नहीं हुई, that you may not have asked, but this is important to ask. That also tells you that there is no chronic kidney disease. If she has attained menarche at correct time, then it is not, it doesn't unlikely that she has chronic kidney disease. Okay? So ये देवयान, अब तो तुम्हें एग्जाम देना है. You have to present history, past history, personal history, family history. Now you come to clinical examination. बताओ
पास्ट हिस्ट्री में बेटे जो हमने बताया ना वो
सारा आना है.
हाँ बता देना है. ये नहीं कहना no significant past history, no history suggestive of a CKD in terms of nocturia, polyuria or this thing, no history suggestive of aches and pains, no history suggestive of tiredness, fatigability, so anemia, rule out of इस तरीके से है. Just to say that yes, this patient does not have any significant past history. ठीक है? हाँ जी.
Examination बताओ.
So general examination, she is alert, conscious, oriented to time, place, and person. Blood pressure was 130/86. Pulse was 90 beats per minute. Regular, no radiocumulate delay. Equal in all limbs. Respiration was 20 beats per minute. Normal. Temperature was normal. There was pallor present. Jaundice was present, and edema was present. There was no cyanosis or clubbing. Neck vein, neck glands, there was no visible pulsation in the neck veins, no palpable neck glands. There was a right IJV HG catheter in situ, and
what all in the examination would you say can tell you that she had chronic kidney disease? One is anemia, but anemia can be in acute also. So what else?
Any bony deformity?
चलो rickets, any signs of rickets? चलो ठीक है. और
आइस में बताया था ना अभी.
आइस में बैंड की रेटोपैथी इज chronic kidney disease. तभी मैंने पूछा हैं. ओके, व्हाट एल्स?
नेल्स में क्या देखते हैं?
Chronic hypertension के changes आईज में हो, वो भी है. Left ventricular hypertrophy हो, वो भी है. Then if there is absent reflexes, नहीं? If you have no ankle reflex, in the absence of a disease causing neuropathy, then it is a sign of chronic kidney disease. नहीं? Is that right? ये important है, याद रखना है. Many examiners will ask you, did you examine the reflexes? So you can't get away by saying.
Do we not have a facility of chat box where the other students can ask questions?
हाँ, there is.
अच्छा, मैंने देखा नहीं कि chat box में normally questions पूछने शुरू हो जाते हैं लोग. बच्चे की क्या उनके मन में कोई है तो वो I think they can ask in the chat box. I don't see the chat box.
Yeah.
ठीक है
बेटा. पुनीत होता है ना?
Yes sir, they can ask sir. Yes sir, there is a facility sir. They can ask, and even sir, a faculty can ask questions which they can reply over the chat box.
Okay.
Yeah. अच्छा.
चलो ठीक है. So I hope everybody agrees to the fact that in any patient who has acute kidney injury, as per your history, you must rule out chronic kidney disease, because bulk of the CKD presents as an acute history, as a history as if there was nothing 5 days back, right? And when you do the creatinine is 14, right? So the history tells you, and then in the examination, the points that we just mentioned tell you that there is no chronic kidney disease. Right?
Okay. Let me ask the question to the audience or to the other students if they can answer. How do you classify AKI in children? Is there any specific classification or definition for that matter? You know, it's very important for us to define AKI nowadays. We've had hundreds of definition given, and now the definition, based on the definition only, we can sort of decipher whether this patient has AKI, right? So any specific classification and staging of AKI in children?
बताओ भाई, anybody in the audience?
तुम बता दो भाई, ये तो सब शांत है.
In children, normally AKI is defined as rise in serum creatinine of more than 0.3 milligram from the baseline, or rise in 1.5 times the baseline creatinine, or decrease in the urine output of less than the 30 ml per minute in and
0.5 ml per kg
per hour in the last 6 hours, and the creatinine rise should be within the past 7 days.
So ये तो KDIGO की क्लासिफिकेशन है, ठीक है? एक होता है पीडियाट्रिक राइफल, पी राइफल, वो सुना है कि नहीं सुना? And you know, when you calculate creatinine clearance in a child, which formula do we use? That's important because we take into account the body surface area. Okay, which formula do we use? Short's formula. Okay, so it's important whenever a patient with AKI comes to us, we need to stratify. We need to very clearly stratify what type of a patient is likely. As you said, the patient must have been requiring ICU admission and requiring a plasmapheresis. So we need to find out the criteria to stratify. Okay, this is a theoretical question, but it's extremely important for us to manage such patients based on the pre-test. Nowadays, people do a pre-test, something known as renal angina index. Have you heard of the term renal angina index? RAI? पे
लिख लो देव्या, सब चीजें पढ़ना बैठ के, ठीक है?
Renal angina index क्या चीज है and how is it different from the traditional rifle criteria? Okay, in children especially, this is
हो गया मेरे को लग रहा है.
Based on the patient's characteristic and the severity of AKI, we give a renal angina index, and this was actually brought out by an Indian who's now in US, of course, Dr. Basu. So this is a very important predictor to find out what will be the severity and what will be the mortality and what the patient will require in future. Okay?
ठीक है देवयान, तो अब ये बताओ, now you tell us what is the diagnosis that you have made and what is the differential diagnosis based on your history, examination, and urine findings. बता दो, because that is part of your examination. What is the urine finding at admission? बताना. No, you have to. No, you are mute. Debya.
Hello.
Right.
Yes. So on admission, urine dipstick protein was 3+, erythrocyte 3+, specific gravity of 1.01. In the microscopy, there were full-field RBCs, plenty of RBCs throughout the field. So there was proteinuria of 3+ with plenty of RBCs, full-field RBCs in a routine urine.
Okay. And so what did you think of? You thought of a glomerular disease or an interstitial disease?
Like a glomerular proteinuria.
Right. So now tell us, what are your differential diagnoses, or the first diagnosis, second diagnosis?
First diagnosis is a thrombotic actually required RBC.
ऐसे नहीं बोलो, पहले तो syndromic diagnosis बोलो.
Syndromic diagnosis is acute kidney injury. Etiological diagnosis first is a thrombotic microangiopathy, probably in HUS, as she required multiple transfusions, and also there was evidence of glomerular hematuria with hypertension. Second possibility is an infection-related GN is also a possibility because she had an infection and followed by a glomerulonephritis. So this also we have, and although 3+ proteinuria and is uncommon in interstitial nephritis, but she received multiple drugs. So acute interstitial nephritis secondary to antibiotics or NSAIDs can also be a possibility.
You are not considering vasculitis at all?
So he's considering HUS as whatever you can call it as. I would keep as a person, if I go by the history, what you gave an examination, I would still keep a possibility of underlying chronic kidney disease with acute AKI, probably due to either a diarrheal disease or a multifactorial, right? Rather than keeping the third as your, because the fact that she had anemia. So the more important thing is anemia, which can be explained by HUS, very rightly correct. But interstitial nephritis normally would not produce that degree of anemia, right? It's the other way around. Normally the tubules are the ones who are this thing, but acute interstitial. Chronic TIN can have anemia out of proportion. So possibility of a chronic kidney disease with an acute insult, whether it is diarrheal or antibiotics or something else, right? Third possible. I'm not saying it's first. The first, we agree that it is probably which type of HUS? So diarrheal HUS or non-diarrheal or
typical, atypical.
Atypical or atypical, right?
Typical HUS, right? Okay. So why haven't you kept vasculitis as a second diagnosis? Anything specific? That you didn't keep it at all, consider it at all?
Joint pain, rash.
Okay. She had abdominal pain.
She had abdominal pain, but
and she had blood in the stool.
Yes. But it settled down after 3 to 4 days of IV antibiotic and conservative management. So probably it was a GI infection than a vasculitis, which I think should have been persistent.
And she didn't have a rash. You can argue that way. That she didn't have any systemic features of vasculitis.
Other possibility can be, an underlying what is known as malignant hypertension. It can be a secondary malignant hypertension, but because of the fact that her blood pressure for her age and other things were quite high, and she had a rapidly progressive renal failure, we have not discussed the fundus findings. So that becomes an important thing in this, that as sir was saying earlier, whether she had any changes suggesting a fundus exam, she could have been important in this case. So other possibility could have been a malignant hypertension apart from TB.
Okay. Now, Debayan, tell me, how will you go about? We agree with your diagnosis, set of diagnosis. I think anybody will keep number one as HUS, right? So now tell us, what investigations did you do and what favored what? So tell us in the CBC, what did you find?
Hemoglobin was 4.5, total counts of 5,900 and platelet counts of 21,000. It was on our presentation.
So there is thrombocytopenia and there is significant anemia. Okay.
Yes. And on RFT showed a urea of 130 with a creatinine of 7.2.
No. Will you also tell us what did the peripheral smear show?
Peripheral smear shows normocytic normochromic anemia with 2.5% cystiocytes. Reti count was also increased. It was 7.3. Corrected count was 6.4. So it was.
Why do you say it's normocytic normochromic anemia? Why not hemolytic anemia by the peripheral smear? इसमें शिस्टोसाइट्स और उन्हीं थे क्या? With retics being high.
Sites, but the size and the volume of RBC was normal. So
okay, from that angle you are saying, but the overall picture was suggestive of hemolysis, no?
Yes.
Right. Okay. Then
this was a CBC with the peripheral smear.
Yes. Then
other investigation, we did RFT and LFT. RFT showed a urea of 130 with a creatinine of 7.2, sodium of 136. Potassium of 4.5, calcium of 8.6.
Yes.
So there was renal dysfunction with a creatinine of 7.2 with no normal electrolytes. And the LFT showed a bilirubin of 5.2 with an indirect bilirubin, 100% were indirect bilirubin 5.2. The enzymes were slightly raised. SGPT was 25, SGOT was slightly raised, it was 75. And GGT was normal. We also did a LDH, which was 3,556. So all these initial investigations favored hemolytic anemia.
Right.
With thrombocytes.
Right. What else did you do?
We did a complement analysis.
Okay, complements, right? What did
complement? C4 was normal, C3 was slightly low, 64. In our lab, it is 80 to 150.
Yes. Okay.
And we had also sent the ANA, ENA and
ये C3 का क्या significance क्या है बेटे? तुमने बताया तो था C3 low है. Is there any significance in your case? Prognostic significance होता है. Low C3 has, does indicate a severe disease. Okay? ठीक है बेटे.
और बोलो. और investigations में क्या किया next?
We did a ultrasound.
वो बहुत important है.
Ultrasound में क्या था?
क्या कर?
Hello.
Ultrasound बेटे क्या बोला?
Right kidney was 9.9 into centimeter and left kidney was 10.7 into.
So nearly normal size. और क्या था findings?
Sorry, sir, I have a problem in my connections. Hello.
Yes, बेटे आप audible है?
Yes, sir. So ultrasound KUV showed right kidney of 9.9 into 4 centimeter and left kidney of 10.7 into 4.2 centimeter. So normal size kidneys, increased echogenicity in bilateral kidneys, no obstruction or no obstructive nephropathy, no hydronephrosis or calculum.
What does this increased echogenicity reflect in your patient?
Increase echogenicity का क्या मतलब होता है?
Suppose if we do a biopsy in this patient, right? Suppose, will it correlate with any biopsy findings? That's what my question is. Did we do biopsy in this patient or no?
No, sir.
Okay. So that reflects the IFTA. It correlates very well with IFTA. And that will indicate the prognosis. Okay?
Either IFTA or interstitial edema. When both will go increase echogenicity. Okay? So whether it is edema or fibrosis, both will raise the echogenicity. That is why you have increased echogenic kidneys in AKI as well as in chronic. In chronic, it is more because it is more reflective of fibrosis. The higher the fibrosis, the more tough to locate the kidney vis-a-vis in contrast to liver and the spleen. Right? ठीक है?
एडमेट टेस्ट किया था कि इसमें एडमेट?
अब आगे क्या क्या टेस्ट
क्यों किया था? नहीं किया तो क्यों नहीं किया?
सर किया था नेगेटिव
किया था. अच्छा क्यों किया?
For diagnosis of TTP.
Okay. Normally you get a report late, na?
Yes, sir.
ठीक है. So now your clinical diagnosis is well supported by all your investigations, right? So now what will you do in this patient? Of course, you've told us what you have done. What else would you have done?
Thorough complement analysis.
Yes. Right.
Okay. We had sent that.
Okay. What else? Workup for HUS did you do? Did you set antibodies?
Yes, antibodies and the complement analysis both we have.
Both were sent. Okay. But the report is awaited, eh?
The report has come.
Has come. What did it show? देबियान फ्रीज हो गए हो, तुम्हारा नेटवर्क ठीक नहीं है. पुनीत, इसका फ्रीज हो गया भाई.
Yes, sir. There's some problem with the network.
There is no chat box because someone must have asked questions. There is no chat box here. संजीव, तो आपको दिख रहा है chat box है? मेरे को तो share screen, record और reaction नहीं दिख रहा.
Participants हैं बस. हाँ सही कह रहा है. Chat box तो नहीं है.
I'll just check. हाँ basically I just check, sir.
नहीं है, सही कह रहा है. हाँ Debian, you were not audible.
Yes.
Okay.
We had sent the reports had come.
And what did the report show?
Reports show that there was presence of anti-CHF antibodies were present in a large size.
Right. So now, in light of that, what did you add anything, or you thought this is enough?
We had given her pulse steroids for 3 doses and also given cyclophosphamide for 2 doses. We had received 2 doses of cyclophosphamide.
Fair enough. That is what I wanted to know. Okay, did you just do plasmapheresis and supportive dialysis, or did you give her steroids? Because if the antibodies are positive, you ought to give them steroids. Right?
So this could have been brought out earlier, because you, in the management, you just mentioned that patient underwent a series of plasmapheresis. You either you don't say she underwent some procedure, or if you don't know and you've taken the history, then you say that she underwent procedure and received some. We can always ask the patient कि आपको कोई injections बार-बार तो नहीं दिए गए or something of that, to find out whether she was given pulsed steroids or not, right? This is important. Many times patients themselves, but if you are the treating doctor, then you have to tell the full story. You just told us about plasmapheresis. Sanjeev asked you about whether she received steroids or not, right?
So you gave steroids as well as cyclophosphamide, gave her plasmapheresis. Her urine volume has started improving. Is she off dialysis or she is still on dialysis?
Actually, she didn't require dialysis at all. We only did.
Oh, she didn't require dialysis at all. Okay, I missed that. Okay, sorry. Okay, very good. So now what is her creatinine?
Her last creatinine is 2.3, which was 2 days back, and her hemoglobin and platelets has also settled down. HB is around HB is 8.4, which is stable, and platelets is 2.3 lakh. Last plasma was done 1 week ago.
Okay.
We are following
so now you are just giving immunosuppression and no plasmapheresis, and you hope to. But did you do any workup from the angle of Shigella or the
stool culture? Did we do stool culture?
So actually, when she came, she didn't have any. The loose stools had settled down already. So she had received antibiotics in Nepal. So we didn't stay in the stool culture. We did a blood culture, but it's sterile, and urine culture was sterile.
Right.
Anyway.
Chalo, that I think.
अब ये बताओ कि what is the fallacy of serum creatinine in AKI?
So it has a lag time to begin with. After the insult, there is a lag time before the creatinine actually we see the rise in serum creatinine. Also, it takes some time to resolve when the AKI resolves. So
one is that. Yes. Anything else? Does it underestimates or overestimates the renal dysfunction? And why? ये एक important चीज है, ठीक है? इसको पढ़ लेना. Why it overestimates the renal dysfunction, and it is, you are absolutely right. Are there any methods of getting renal functions earlier than 48 hours when the creatinine will rise? What is cystatin C? What is it? I just want to know what is it. कहाँ से आता है cystatin C? Tubules से आता है?
नहीं यार. Have you heard of cystatin C? What is why is it discussed, cystatin C? It is believed to be a better marker of renal function than creatinine. No?
Yes.
So, and is it available to measure?
नाश्ता में तो है.
Is it freely available? Right? You ask your lab people, they will be doing cystatin C. Delhi labs, lot of labs do cystatin C. Right?
बेटे हर cells में होता है, हर cells में ये protease, cystatin protease inhibitor से आता है और हर cell में होता है. Tubules में metabolize हो जाता है fully. इसलिए it is a better marker than creatinine, and people are now, and it is available, as Sanjeev is saying. Most of the good hospitals have availability of cystatin C. Short of that, what any marker which can detect AKI at an early stage, earlier than 48 hours? यार AKI के markers तो आप सारे
क्या बोल रहा है यार, NGAL ये सब क्या है, इतने सारे तो भरे पड़े हैं. You have to be told. You should say 1, 2, 3 IL this that, है ना? ये तो तुम लोगों को सब पता होना है. एग्जाम गोइंग हो, you should know all these things.
ये क्या होता है कि नेफ्रोलॉजी में बहुत सारे फिजिकल फाइंडिंग्स तो होती नहीं है, ठीक है ना. So the discussion is on management. Management consists of both investigations as well as treatment. ठीक है. So you have to be prepared for these questions. And in fact, they will ask you about more things. What is furosemide stress test? How is it being used nowadays in ICU? सुना है furosemide test?
सुना है तुमने देवयान या नहीं?
सुना है सर, एग्जैक्टली
पढ़ लेना. ये सब तुम्हारी टेक्स्ट बुक्स में दिया हुआ है. इट इज नथिंग दैट इज कि कल जर्नल में आया है 22 में, ऐसा नहीं है. इट इज देयर इन योर टेक्स्ट बुक्स. ऑक्सफोर्ड टेक्स्ट बुक ये पढ़ना, इट ऑल देयर. ठीक है. I think Devyan, you've done a good job.
Very good, very good. एक और last question मेरे मन में है, क्योंकि I want them to understand these questions very well. See, nephrotic syndrome is very common in children, right? Can we have AKI in nephrotic syndrome, and what are the causes of AKI in nephrotic syndrome? Now, more and more with the newer classification and newer staging of AKI. Earlier, when we were students, we used to be told that nephrotic syndrome does not result in AKI, but now it is considered as one of the very common and prognostically bad complication of nephrotic syndrome. So what are the causes of AKI and nephrotic syndrome? Just enumerate so that others will also learn. This is a learning exercise, right? So these are important questions in nephrology which are asked.
First, there is dehydration. There is actually intravascular volume depletion, which can lead to dehydration.
Very good. Chalo, one.
Secondary infections, which are very common in nephrotic syndrome.
Sepsis, AKI, okay.
And venous thrombosis.
Okay, venous thrombosis.
Renal vein thrombosis. Say renal. Yes.
Renal venous.
Okay, what else? Interstitial nephritis, secondary to
drugs.
Drugs. Furosemide itself causes interstitial nephritis. No? Then what else? ACE inhibitors, ARBs, if you use. Right?
क्या कहते हैं आजकल चेंज हो गया, हाइपोवोल्यूमिया वाली थ्योरी थोड़ी सी पुरानी हो रही है. They are talking about vasoconstriction, severe vasoconstriction. ठीक है, but read about it. You should. This is a very, very, and among the drugs, apart from these two drugs which you mentioned, you should know about these recent, anti-malignant drugs. I'm just giving you a few which can cause AKI. ट्यूबुलर डिसफंक्शन. कुछ याद है, कुछ है, कुछ भी नहीं? आजकल जनरल कप में यही चल रहा है हर जगह.
रेट्रोवायरल एजेंट्स यही आते हैं, है ना?
काइनेज इनहिबिटर्स है ना. ठीक है. नहीं, बट ओवरऑल ठीक है बेटा. बट योर प्लान
nicely done, Devyan. But I think your history was totally biased towards HUS.
वो नहीं होना
चाहिए. It should not happen, है ना?
और ये पढ़ लेना सारी नई चीजें. How do you calculate volume overload in ICU in children, especially?
So normally in adults we by two methods, by clinical assessment and radiological methods. Like clinical we see signs of fluid overload like presence of bilateral crepitation, edema, raised JVP. In radiological investigation, few of the investigation that we can do. First is a chest X-ray, which shows if there is edema, it will show bilateral perihilar prominence. And secondly, ultrasound chest, presence of B lines. Then
point of care ultrasound is important, right?
Yes.
And IVC में क्या देखते हैं?
If it is IVC is more less than 50% collapsible and it is dilated, then the patient is likely a volume overload.
ठीक है. संदीप, anything?
हाँ, नहीं देवयान, you are good यार. 7 out of 10. ठीक है, you are through. No problem. बस पढ़ लेना और जाके. ठीक है.
And thank you, Sanjeev, for giving me a chance.
नहीं.
I also learn a lot.
Pleasure. नहीं.
Thank you, sir.
Okay, Devyan, well done. Okay, keep it up. Chalo.
Thank you so much, faculty. Thank you, sir.
Okay, Puneet, bye.
Thank you, sir.